First of all, I would like to thank Rahul for arranging this nice session. He is always proactive. So first of all, I would like to thank him, and later on, thank you to all participants who are attending this lecture. So today's lecture, we are going to present on electro-diagnosis, reading a report. Electro-diagnosis, reading a report. So here the purpose of making this lecture is such that even if you don't perform EMG MCV, at least when the patient comes with the report, we should be able to interpret. Okay, whether we have passed BPT or MPT, it doesn't matter. Clear? Even if you are having a degree BPT also and you have never seen the machine, then also at least you should be able to interpret report. Okay. Because what I have observed, actually, this is not part of any curriculum or nowhere it is as topic. So this topic was presented in one conference, Physio Summit at Vadodara, by thinking that many times as a physiotherapist, what I have observed, that we are more confident in interpreting reports done by other professionals. Like if the pathologist has done blood glucose level, okay, so we are able to tell that the patient is having diabetes or not, and we are telling with confidence that, sir, madam, you have diabetes. Okay. When the report is coming from radiologist, okay, so without seeing report, okay, directly from X-ray, we are telling that, sir, you have ACL tear from the MRI or soft humerus fracture from X-ray. Clear? So the reports done by radiologists and pathologists, we can identify them, we can interpret them. But EMG NCV, actually it is done by physiotherapists, but still it is observed that many physios, they are not able to interpret the report. Clear? So I think you all will agree with me. So instead of commenting more on reports of radiologists and pathologists, we should increase the level of our profession. Okay, so here the lecture is designed in such a way that after attending this lecture, you will be able to interpret reports that is done by physiotherapists. Clear? So here the lecture will be covering all the aspects. So even if you have not studied any single part of the investigation in your UG or PG, or even if you have not studied, then also you will be able to interpret. Okay. Performance, if you have done, that is quite better. But even if you have not studied, okay, then also you will be able to understand. So we will be going like this. That first of all, we will understand the terminology of each and every investigation, okay, and then how to interpret. Okay, but again, the time will be limitation, so I will not be able to explain with all these examples. So I have covered few examples. Remaining, you can refer from the book. Okay, so you will understand. The concept should be clear from this lecture, then you can revise it. Okay, so let me ask again, am I audible properly and the PPT is visible to all?
Yes, sir. Yes, sir, completely.
Okay, fine. So you can see on the screen, we have classified electro-diagnosis into two parts mainly. One is traditionally used and another is recently used. So traditionally used, that is strength duration curve, that is SD curve. It is also known as intensity time curve. And another is FG test, that is Faraday galvanic test. It is also known as reaction of degeneration test. Now SD curve and FG test, I think you all will remember, okay, in most of the batches I have taken. Clear? So if you have any doubt, you can ask later also regarding this SD curve and FG test. But we are not going in detail for this. The lecture is limited for this recently used electrodiagnostic test. So it includes EMG. EMG means it is, I need answer. EMG.
Electromyography. Electromyography.
Electromyography. Good. Okay. What is EEG?
Electroencephalography.
Electroencephalography. Okay. What is ECG?
Electrocardiography.
Electrocardiography. What is EGG? What is EGG? Okay, EGG is raw material to prepare omelette. Okay, egg means so it is not investigation, but the way you thought of the investigation, that shows that you are interested in this lecture. Okay, so now coming to EMG, so that is electrical activity occurring in muscle. It includes needle EMG as well as surface EMG. Needle EMG, the name itself it is telling it is done with needle, so that is invasive procedure, and surface EMG, so it is done with surface electrodes. NCV, nerve conduction velocity. So if you are going for motor nerve, it is known as MNCV, motor nerve conduction velocity, and if you are going for sensory, it is known as SNCV, sensory nerve conduction velocity. Then coming to late response, so it is F-wave as well as H-reflex. So here it will be useful to diagnose any problem at proximal axon. So that is nothing but radiculopathy. Another is repetitive nerve stimulation, that is commonly known as RNS. So RNS, it is for neuromuscular junction abnormality. And then evoked potential. So evoked potentials, those are used for central nervous system dysfunction. It includes motor evoked potential, sensory evoked potential, visual as well as auditory. So these all are the tests. Okay, no test you will find out of this hierarchy. Now, starting with the NCV, nerve conduction velocity. So now you might be remembering the limitations of SD curve. Can anyone tell what are the limitations of SD curve?
The site of the lesion cannot be determined.
Very good. Okay, site of the lesion cannot. Okay, anything else?
Sir, it gives only the qualitative data, not a quantitative
Yes,
data.
very good.
Severity of the disease.
So we cannot tell quantitative data from SD curve, and we cannot localize the site of lesion. But both these limitations are solved by the use of NCV. We can localize the site of lesion. So where is the lesion? Okay, whether it is 3 centimeter, 4 centimeter, 5 centimeter, proximal to wrist, distal to wrist, or anywhere else, we can localize it. Okay, another is it gives us quantitative data with very much accuracy. Like I can say that the median nerve velocity is 64.28 meter per second. So with the 2 digits after point, we can identify. So here, nerve conduction velocity, both the limitations of SD curve, they are solved by this nerve conduction velocity test. Clear? Okay, but this will be useful only for peripheral nervous system, and it is the unique test for testing of peripheral nervous system. No other test is available in market that can assess your peripheral nervous system except NCV. Okay, so that is very good part of investigation. And one more thing is it is assessing function of the nervous system rather than just structure of the nervous system. Clear? So whenever you suspect any problem in peripheral nervous system, you think of NCV. Okay. Now, just for remembering or just for identification, this is the test that we can perform. Okay, in this, in my hand, you can see it is stimulating electrode. This is the stimulating electrode. Stimulating electrode will stimulate the nerve, and the impulse will go distally. It will be recorded by this recording electrodes. These all are recording electrodes. You can see black color and red color. Okay, now these electrodes are magnified here. So these are known as surface electrode. Cathode, anode, that you know, black is cathode, that is negative polarity, red is anode. Okay, so that is basic part, you will remember. Now, the surface electrode, they are used for EMG also and motor as well as sensory nerve conduction study. For both the purpose, it will be useful, this surface electrodes. Now these are ring electrodes. So if you don't want to use this surface electrode, you can use this ring electrodes. Okay, but this ring electrodes will be useful only for sensory nerve conduction velocity. But the surface electrodes will be used for motor nerve conduction velocity, sensory nerve conduction velocity, as well as surface EMG. Now, here you can see it is ground electrode, so it will be absorbing all surrounding waves except biological waves. Here you can see green color wire. Okay, so that is ground electrode. Okay, so these are the introduction about this instrumentation. So it has, in short, stimulating electrode. These are recording electrodes. Okay, and ground electrodes. Surface and ring, they are either or. Either you can use surface or you can use ring. Okay, both cannot be used simultaneously in ordinary NCV. Now, this is CMAP, that is compound motor action potential. Compound motor action potential. It is also known as M-wave. Okay, it is also known as M-wave. So here you can see A. Okay, A, it is nothing but latency. Latency means what? It is the time taken by impulse to travel from stimulating point to recording point. Okay, it is the time taken by impulse to travel from stimulating point to recording point. So latency is having clinical significance. Now, here you can see the pointer. Okay, so this is depolarization. This is depolarization. This is repolarization. Okay, repolarization. This is hyperpolarization. Again, coming to baseline. We are not going in detail of physiology of depolarization and repolarization, but this complete wave, including depolarization, repolarization, hyperpolarization, again coming to baseline, it will complete our duration, that is B. Okay, so starting from this point to this, okay, you can see the pointer movement, this is B. So that will be your duration. But the duration is not having any clinical significance. Okay, so clinically it is not important except in case of temporal dispersion. Okay, now amplitude, so that is highest point and lowest point. So that will be peak to peak amplitude. Okay, in this example it is C. Whatever you can see, okay, alphabet C you trace, so it will be showing you peak to peak amplitude. Amplitude may be given from base to peak. This is baseline and this is peak. Okay, so that is base to peak. Clear? So amplitude is having clinical value. Okay, clinical significance of the amplitude is such that it shows the number of axons. So if I have a good number of axons, my amplitude will be more, and if I have less number of the axons, amplitude will be less. Same is for SNP. SNP means it is sensory nerve action potential. Sensory nerve action potential. It is same like CMAP, but one extra phase may be seen in case of CMAP. Clear? So that is because of local current flow. Otherwise, parameters are same: latency, amplitude, and duration. Now, formula for MNCV. So it is distance between two stimulating points divided by proximal latency minus distal latency. I repeat, distance between two stimulating points divided by proximal latency minus distal latency. From this formula, so it is clear now that if I want to calculate MNCV, I must be having 2 points of stimulation. Then and then it will be able to calculate velocity. Now again, the question should be why. Okay, we have taken science stream 11th and 12th science. Why? Because in the daytime we need to ask at least 5-10 times why. So here also why. Okay, so the thing is, whenever you are stimulating from wrist, for example, and you are recording from abductor pollicis brevis. So you are stimulating from wrist, you are recording from abductor pollicis brevis. So impulse will pass from nerve, impulse will pass from neuromuscular junction, as well as impulse will pass from muscle. So here it will include now neuromuscular junction and muscle. So it will not give us NCV. What we need NCV, nerve conduction velocity. We cannot take velocity from neuromuscular junction and muscle. So what we are doing, we will keep recording point as it is, that is abductor pollicis brevis. Clear? So now we are stimulating from elbow also. Initially we stimulated from wrist, then we stimulated from elbow. Clear? So it is also including now neuromuscular junction and muscle. Now what we are doing, we are having common component from wrist to FPB. So that will be deducted from total part, that is from elbow to FPB. Clear? So simply you think or imagine, okay, we are not in physical classroom, so you have to imagine also elbow to APB minus wrist to FPB. Clear? So wrist to APB part will be deducted. So that is excluding neuromuscular junction and muscle. Is this clear? Okay. So why we are taking 2 points of stimulation? Just because we want to avoid the residual latency in case of MNCV calculation. Residual latency means what? It is the time taken by impulse to travel from neuromuscular junction and muscle. Yeah? So that we want to get deducted. Now, simply think of velocity. Velocity means, as per physics, it is distance divided by time. So we are directly taking the distance, okay, from wrist to elbow. Okay, so that is distance divided by proximal latency minus distal latency. So we cannot get time directly. Okay, I would like to give one example here. You just think that you are starting from Chotila to Rajkot. Okay, so that is wrist to APB. Okay, and you are also starting from Ahmedabad to Rajkot. So now you have proximal latency, that is Ahmedabad to Rajkot. Okay, so you need 4 hours to reach. So that is your proximal latency. Now you also have time to reach from Chotila to Rajkot. Just consider 45 minutes. Clear? So now you have time to reach from Ahmedabad to Rajkot. You have time to reach from Chotila to Rajkot. Now you can calculate what will be the time to reach from Ahmedabad to Chotila. Okay, so that is pure now. In between Chotila and Rajkot, you can consider it includes neuromuscular junction and muscle also. Clear? Okay. So here distance can be measured by 2 ways. Either I can put the distance from Ahmedabad to Rajkot minus distance from Chotila to Rajkot. That is also fine. In other case, you can directly measure the distance from Ahmedabad to Chotila. Fine. So that is distance between 2 stimulating points divided by proximal latency minus distal latency. Is this clear? Up to this clear? Okay.
Yes, sir.
Yes, sir. Yes, sir.
So
Yes, sir.
fine. So this was somewhat difficult to understand, especially when we are not in physical classroom. Okay. Now the sensory nerve conduction velocity formula, it is very easy. That is distance between stimulating and recording point. Here we don't have neuromuscular junction and muscle. So directly you can go with 1 point also. Here you don't need 2 points. In MNCV you saw that there are 2 points. In SNCV we need only 1 point. Why? Because there is no question of residual latency. So that is directly distance between stimulating and recording point divided by latency. Only latency. No proximal, no distal. Why? Because there is only 1. Now we have few parameters. Latency. So as we discussed, it is the time taken by impulse to travel from stimulating point to recording point. That is latency. Okay. Now, if I tell that the time taken by car to reach from Ahmedabad to Rajkot, it is 4 hours. But if I reach in 3.5 hours, so is it considered abnormal? No. Okay. Because I am reaching in lesser time. Okay. Instead of 4 hours, if I am reaching in 3.5 hours, so that will be lesser time. Clear? So latency less is not problem. Okay. Latency more is problem. For example, instead of 4 hours, I am taking 5 hours to reach from Ahmedabad to Rajkot. So definitely we can say that latency is affected. Latency is problem. So that shows abnormality. What abnormality? Roads are not good. Okay, so here the latency, if it is increased, definitely the nerve is affected. But latency less is not problem. Clear? Now coming to amplitude. So amplitude is suggestive of number of axons. Amplitude is suggestive of number of axons. So definitely if the amplitude is more, so it is not problem. On the contrary, it is good that my nerve is having good number of axons. But if the amplitude is less, definitely it shows that there is axonal degeneration or axonal loss. Now coming to velocity. So velocity is also, if it is more, it is not a problem. Okay, it is good. But if it is less, okay, then definitely it is problem. Clear? If the company tells of a car or bike that you will be able to reach 100 km/h with this bike, but if you are reaching 110 km/h, so it is not problem, it is good. But if you are reaching only 70 km/h with full speed, with full accelerator, then it is problem. Clear? So latency more is problem, amplitude less is problem, and velocity less is problem. Clear? Latency more, it is suggestive of demyelination. Amplitude less, latency more, it is suggestive of demyelination. Amplitude less, it is suggestive of axonal degeneration, and velocity less, it is suggestive of demyelination. I repeat, latency more, it is suggestive of demyelination. Amplitude less, it is suggestive of axonal degeneration, and velocity less, it is again suggestive of demyelination. Latency and velocity both are telling same thing. Why? Because the velocity is calculated based on latency only. Clear? Formula of velocity itself, it is containing latency. So the clinical significance will be same, be demyelination. Now these all are few abbreviations, you can read it out. NCS, nerve conduction study, CMAP, compound motor action potential, SNAP, sensory nerve action potential, MNCV, motor nerve conduction, SNCV, sensory nerve conduction velocity, MUAP, that is motor unit action potential. All these abbreviations will be found in report. Okay. Now coming to F wave. So F means it is short form of foot, because first of all this was found in muscles of foot. Clear? So here you can consider this is motor now. So whenever you are stimulating with your stimulating electrode, so one impulse will go distally and another impulse will go proximally. As per which law? Anyone? Anyone can answer? This is which law? Okay, Bell-Magendis law. Bell-Magendis law, what it is telling? So now we'll be allowing the impulse to travel in both the direction, but the synapse will allow one-way conduction. What does it mean? That even if I am having motor now, so it will be allowing the impulse to pass distal to proximal as well as from proximal to distal. But the synapse will stop and synapse will maintain one way. Clear? Because you think in this only. So whenever you are stimulating here, so impulse will go distally also, and it will be recorded as M wave. Okay, with this pointer movement, you can see it is M wave. That is nothing but CMFE. At the same time, one impulse will go proximally, and that impulse will return. Okay, now that impulse will be returning, so it will be recorded as F wave. Okay, why this is returning? Because here you have post-synaptic membrane and pre-synaptic membrane arrangement opposite. Like whenever this impulse is going proximally, at that time, what happens? The pre-synaptic membrane will be proximally and post-synaptic membrane will be distally. Impulse is going from distal to proximal, but the synapse is arranged in such a way that it is from proximal to distal. Clear? So in that case, never it will be allowing to travel from post-synaptic membrane to pre-synaptic membrane. Okay, synapse will be always allowing from pre-synaptic to post-synaptic membrane. So this impulse will have to come back. Okay, this impulse will have to come back and it will be recorded as F wave. Okay, now many times this M wave is normal. So now is normal, but F wave latency is prolonged. Okay, so that shows that there is some problem at proximal axon. That is nothing but radiculopathy. So I think that you all are clear with this. When impulse go proximally, it will have to come back. Why? Because in motor synapse, it cannot jump from post-synaptic membrane to pre-synaptic membrane. Clear? Now, F wave is only for motor now, obviously, because if you stimulate sensory now, impulse will be able to travel further proximally. Why? Because in that synapse will be arranged in such a way that pre-synaptic membrane will be distally and post-synaptic membrane will be proximally. So it is only conducted from motor now. Here it will be useful for proximal axon abnormality. So that is nothing but radiculopathy. And normal value of latency, it is in upper limb it should be less than 30 millisecond. In lower limb it should be less than 60 millisecond. Latency less is not problem. Latency more is problem. So always we will be having highest latency value. Okay, like upper limb more than 30 is abnormal. Less than 30 it is good. Okay, so we have to remember. Less than 30 it is normal. In lower limb less than 60 it is normal. Now H-reflex. So F was for foot. Okay, but H is not for hand. Okay, it is for Hoffman. It was given first by Hoffman's scientist. Okay, so that's why it is known as Hoffman's reflex. Now reflex, why they have used? Because in this reflex arc you will be having synapse also. In FL, there is no involvement of synapse, so it was not completing reflex arc. Here, H-reflex is completing one reflex arc. H-reflex, it is nothing but ankle jerk. In ankle jerk, what we are doing, we are stimulating muscle spindle, okay, with this hammer. But here, what we are doing, we are bypassing muscle spindle and we are directly stimulating sensory component of tibial arm. Clinically, when we go for this ankle jerk examination, so with hammer we are stimulating muscle spindle, and that muscle spindle will stimulate the sensory component of tibial arm. Here directly we are stimulating sensory component of tibial arm. So it will be stimulated with submaximal stimuli. Why submaximal? Because if you increase the intensity, it will stimulate motor nerve also. So here the impulse will start. It will enter from posterior side into the spinal cord, then it will cross the synapse, it will stimulate the motor nerve, and again it will be passing into the tibial component of the motor part, okay, and then it will be stimulating soleus, and there will be recording of this H reflex. Clear? Now, H reflex is also known as Hoffman's reflex. So don't get confused with Hoffman's sign. Okay, Hoffman's sign is different. This is Hoffman reflex. So definitely this is also useful for radiculopathy and peripheral neuropathy. But this H reflex is having some limitation that it will be useful for only a few limited radiculopathies like S1 radiculopathy and C6, C7 radiculopathy. So actually there is limitation, but fortunately whenever we have patients clinically, especially when you think of cervical radiculopathy, so most of the patients they will be having C5, C6 radiculopathy or C6, C7 radiculopathy. Most of the time, clinically also we are finding this only. If you think of the lumbar part, so most of our patients will be having alpha S1 radiculopathy instead of all other lumbar pathologies. Clear? So here, clinically, whatever radiculopathies are common, at least they are identified by H reflex. Clear? So even though it is limitation, but fortunately most of the patients can be investigated with H reflex because clinically also we find the same S1 and C6, 7 radiculopathies more. Okay, others are also coming, but it is not like that others are not coming, but this will be common. Now, it is elicited in soleus for lower limb and flexor carpi radialis in upper limb. Okay, and the normal latency value is 29.8 plus or minus 2.74. So this will be minimum and maximum value. 29.8 minus 2.74, that will be minimum value, and 29.8 plus 2.74, that will be maximum value. Now, as we discussed, in latency we need highest value. Okay, so when you add this 29.8 plus 2.74, so it falls around 32.5 millisecond. Clear? So more than 32.5 millisecond, it will be considered as abnormal. So for H reflex, for soleus, more than 32.5 millisecond, it will be considered abnormal. So slow latency means it is prolonged. Slow means definitely it will take more time. Clear? So slow latency, in some of the reports it will be written prolonged latency, okay, extended latency. All these are synonyms based on reporting person. Okay, the words will be different, but they all mean same. So all this they are telling abnormal dorsal root function. Dorsal means sensory only. This is checking sensory component. Clear? So this was regarding H reflex. Now repetitive nerve stimulation. So in this we are giving stimulus repetitive. Okay, so we are giving 10 stimuli. Okay, and we will compare that what is the difference in percentage between first and fifth or first and fourth stimuli. So based on that, we will be able to identify the fatigue. Okay, like first amplitude was 10 milliwatt and the fourth or fifth was only 7 milliwatt or 8 milliwatt. So we can say that if it is 8 milliwatt, so on the fifth stimulation, there was 20% reduction in amplitude directly from 10 milliwatt to 8 milliwatt. Clear? So 20% decrement. Okay, so that is nothing but fatigue. So it shows that the patient is having some problem in neuromuscular junction. Yeah. So neuromuscular junction abnormality means it is nothing but myasthenia gravis or Lambert-Eaton myasthenic syndrome. Yeah. So we will be able to identify whether the problem is at the neuromuscular junction or not. Okay. If you suspect this decrement, okay, up to 8% decrement, it is normal. But more than 8% decrement, it is suggestive of abnormality. It shows that there is some problem in neuromuscular junction. Now the second question will be whether it is at presynaptic membrane or postsynaptic membrane. Okay, so for that you need to go with low rate and high rate RNS. Low rate means less than 5 Hz frequency you should set, and high rate means more than 5 Hz frequency you should set in machine. Okay, so here we will be able to identify whether it is postsynaptic membrane problem, that is myasthenia gravis, or it is presynaptic membrane problem, that is Lambert-Eaton myasthenic syndrome. Now, coming to EMG. So EMG means it is electromyography. So it includes 3 activities. One is insertional, another is spontaneous, and voluntary. Clear? In all 3, the name themselves, they are explaining their importance. Okay, insertional activity. Insertional means whenever you are inserting needle inside the muscle, at that time, whatever the activity is visible on screen, it is known as insertional activity. Okay, so it is continuous present tense. Here I am inserting needle, at the same time I am seeing this activity on screen. Now spontaneous. Spontaneous means automatic, without anyone's effort. Okay, automatic, spontaneous. Okay, so needle is already inside the muscle. Therapist is not moving the needle. Okay, and patient is not contracting muscle. So here the needle itself, it is not moving. Okay, needle itself, it is not moving, as well as patient is not contracting muscle. So ideally there should not be any activity. Okay, ideally there should not be any activity. But if activity comes, it is spontaneous, automatic. Yeah, so it is spontaneous activity. Then coming to voluntary activity. So voluntary activity, name itself it is telling, whenever the patient is contracting muscle, at that time you will be having activity. Voluntary activity may be taken by two ways. Minimal. Minimal means with simply active movement, and maximal means it is with resistance. Why we need both? Because when we go for simply active movement and we are recording minimal voluntary activity, so it will not recruit fast twitch fibers. But in case of maximal, it will also include fast twitch fibers. So just to differentiate between slow twitch and fast twitch, we are taking minimal activity, that is without resistance, and maximal activity with resistance. Clear? Okay. Maximal voluntary activity, it is also known as interference pattern. So you should be able to understand whenever you write or you read this from interference pattern from the report. Clear? So interference pattern means with resistance. Many times it will be written IP, simply IP in report. Now, as we discussed, insertional activity, it is spontaneous potentials of the electrical activity. Many times it is possible that here you are inserting needle inside the muscle, and at the same time you miss the activity on screen because you cannot concentrate at two places simultaneously. So in that case, you don't need to take the needle outside and reinsert because you are making second puncture. Just reposition the needle, so that will also give you activity. Okay, and the reason for this insertional activity is muscle membrane excitability. So because of circulating acetylcholine's, you will be having excitability of this muscle membrane. Normal value is up to 300 millisecond. Spontaneous activity, so as we discussed, ideally there should not be any activity because needle is also not moving, as well as patient is also not contracting muscle. So definitely it is known as electrical silence. Okay, as it is electrical silence, there should not be activity. If activity is visible on the screen, it is suggestive of abnormality. Okay, so just the presence of activity itself, it is diagnostic of abnormality. Clear? Now, there are two exceptions where we have to consider this spontaneous activity as normal also. Why? Because it is possible that in first case, patient is not relaxed. As this needle, it is invasive procedure, so definitely the patient may be under stress or anxiety. So in that case, it is possible there will be contraction of the muscle just because of excitement, anxiety, stress. Okay, so in that case, activity will be visible on the screen. So actually it is not spontaneous, it is because of muscle contraction. Okay, even though it is at subconscious level, but it cannot be considered as involuntary contraction. Clear? So patient is not relaxed. So in that case, you just assure your patient to be relaxed. Second is anti-plate potential, because it is possible that we are inserting needle into the neuromuscular junction. Okay, so definitely you will be having nerve fibers; those will be sensitized by our needle. So that will be also one of the exception. In all other cases, just appearance of the electrical activity itself, it is proving abnormality. Clear? Now, this type of the MUAP will be formed. MUAP means motor unit action potential. In few machines, it will be written MUP also. So that is also same, motor unit action potential or motor unit potential. Motor unit, that we know, okay, it is anterior horn cell, its axon terminals, neuromuscular junctions, and all muscle fibers supplied by that single axon. Collectively, they are known as motor unit. Clear? So all or none law on all this laws we are learning for motor unit. So here in MUAP, you can see these are three phases. Number one phase, number two, and number three. You can see this amplitude, that is from highest point to lowest point. So amplitude is suggestive of density of muscle fiber. So density of muscle fiber more, definitely the amplitude will be more. If the density is less, amplitude is less. So that was histological correlation. But clinically, if we see, so this amplitude of MUAP can be directly correlated with muscle strength. You will find many research articles also. So directly it can be correlated with MMD. More your MMD, more your amplitude. Clear? So you can use this MUAP amplitude, okay, of EMG for research purpose also, because it gives you objective measurement of muscle strength. MMD is subjective measurement, okay, 1 RM, 2 RM, that is objective measurement, and even better, it is your amplitude of MUAP. Now duration means it is from the starting point to end point, that is duration. Clear? Duration, it is based on the size of muscle. If the larger muscle, duration will be more, because from peripheral most fiber, whatever the time is required by that fibers to pass this impulse to needle, that will be considered as duration. So definitely larger the muscle, there will be more time, so there will be more duration. But again, the duration is not having much clinical significance even in MUAP also. Now these are phases. So here you can see 3 phases, and you have turns also. So here it is turn. Turn means it is changing its direction without touching baseline, and phase means it is changing its direction after touching baseline. So this is the difference, basic difference between turn and phase. Yeah. So turns and phase, they are suggestive of synchronicity of muscle fibers. Like if you consider one motor unit and all these muscle fibers, they are contracting together. Okay, so you will be having proper phases, only 3 phases or 2 phases. But if all of them are contracting separately, okay, one by one, and will be multiple phases or multiple turns. So phase and turns, they are suggestive of synchronicity. Okay. One is frequency. Frequency means how many MUAPs are formed in 1 second, that is frequency, and sound. Sound means that is also one of the characteristic for diagnosis purpose. So this is how the MUAP is formed, A, B, and C. So A is formed whenever the impulse is passing towards the needle. B will be formed whenever the impulse is passing away, passes under the needle, and C will be formed whenever the impulse is passing away from the needle. So this is A, B, and C. Impulse passing towards needle, under needle, and away from needle. Now these are the parameters. We have to remember there is no option. Amplitude is ranging from 100 microvolt to 2 millivolt. Duration is ranging from 5 to 15 millisecond. Shape is either diphasic or triphasic. Sound is clear, distinct thump. Clear, distinct thump means as some heavy object is falling from height. Sorry. Now frequency will be 30 to 50 per second, and interference pattern, so that range from 2 to 5 millivolt. Actually more than 2 millivolt, it is quite good. Generally in our layman people, we are not getting this amplitude more than 2 millivolt. It will be there only if we have athlete as our model or patient. Okay, so as a subject, if you are having athlete, then and then you can get amplitude more than 2 millivolt. Now last investigation done by this particular system, that is EVOKE potential. But frankly speaking, no one is doing this EVOKE potential, because we have some other investigations those are already existing for central nervous system. So generally we rely on MRI and CT scan, mostly on MRI. But still we can just have a look on this. There will be stimulation at one point and it will be recorded at different 4 points. Okay, so depending on this location of recording, we will be having different graphs on the screen. Okay, you can see here there is electrode placement throughout this placement of pathway. Okay, so here you can see on the scalp, you can see on the brachial plexus, you can see on the wrist. Okay, so all these are different placements. Now, just we think for somatosensory EVOKE potential. So here what we are doing, we are stimulating from distal component, okay, and we are recording from different aspects of this sensory pathway. So this is one of the useful technique, and it is non-invasive. We don't need, or we don't need to use any type of the needle here. Okay, so it is just a non-invasive technique. So you can see in this diagram, if you think of the medium nerve, somatosensor evoked potential, stimulation will be given at wrist, and it will be recorded at C5 spinous process. It can be recorded at ipsilateral ops point. It can be recorded at contralateral ops point. It can be recorded at cerebral cortex, and this is frontal zero. Zero means it is midline. Yeah, so it will be recorded at different places. Now, this type of montages, they will be there. So what will be the latency between cerebral cortex and frontal zero? What will be between cerebral cortex and contralateral ops point? What will be between C5 spinous process and contralateral ops point? And what will be between ipsilateral and contralateral ops point? So this type of the graphs will be seen. N means negative, P means positive. N means negative, P means positive. So here N20 means what? N means negative. Negative means it is above the baseline. Negative means it is above the baseline. Okay, above the baseline, it is considered to correlate with depolarization. That's why it is given negative. Otherwise, you can think of negative, positive on any side. Okay, whenever you are plotting graphs, so negative can be put upside also, downside also. It is up to your convenience. But here it is correlated with depolarization. That's why the negative is taken above the graph. Okay, above the baseline. Now, 20 and 20 means what? So here you can see this is sweep speed. Okay, so that is kept 5 millisecond. 5 millisecond means 1 centimeter in the graph. Okay, so that is large square. Many times you have simply large square. So here you can see only large square. In few graph papers you will be having large square, and that one large square will be having 25 small square. Okay, so you can think of one large square. And if you don't want to fall in this confusion of large and small square, just to consider 1 centimeter. Okay, so 5 millisecond, it is 1 centimeter. So here 1, 2, 3, 4. Okay, so here you have this peak of the amplitude. So 4 means total 5 into 4. So that is 20 millisecond. You can think of this P25. P means it is below the baseline because it is considered or correlated with repolarization. So here we have to identify this location. So let us start. 1, 2, 3, 4, and 5. Okay, so 5 means 5 into 5. 5 centimeter multiplied by 5 milliseconds. So it is 25. Yeah. So in this similar way, we have N13, okay, N9. Okay, all these are calculated like this only. So if any particular latency is prolonged, so we can say that, okay, there was problem between these 2 points, or in this montage, there was prolongation of latency. Now, same is for TBL SSEP. So we have to stimulate here. So that is posterior side of medial malleoli. So stimulation is given, and it will be recorded at knee, popliteal fossa, lumbar region, thoracic region, cerebral cortex. That is cerebral cortex 0. Okay, 0 means midline, frontal 0. So it will be recorded, and you will be having this type of the recording. Yeah. So here sweep speed is 10 milliseconds. So if you want to identify any particular montage, so that is 1, 2, 3, 4. Okay, and fifth is half. Okay, it is not complete. So you can see one peak, that is N45. Okay, 4.5 square or 4.5 centimeter multiplied by 10. So it comes around 45, N45. Similarly for P37, N22, etc., etc. Now, motor evoked potential. So here the stimulation will be given at the cerebral cortex, and it will be recorded at different locations like spinal cord and upper limb, lower limb based on requirement. Clear? This stimulation will be either magnetic or it may be electrical also. Clear? And it is also having very good use in intraoperative neuromonitoring, where the electrodes are placed and continuous stimulation is given. Okay, and there will be generation of the potential in operation theater. So by mistake, if the surgeon touches any neural component during the surgery, so this potential will be disturbed. So that guides the surgeon that this is the structure not to cut. So it will be having good role in intraoperative neuromonitoring. And at many places, our physios, they are going also in live OT, that they will be responsible for this intraoperative neuromonitoring. So that is very good explored area of this electro-diagnosis. Now here again, you are recording from this C7 spinous process. You are getting this type of the recording. You are also recording from abductor digiti minimi, and you are getting this type of the potential. Same for lower limb, for TBLH anterior. Okay, now coming to report. So I think that you all have revised this basic theory part, okay, for this interpretation of report. So we are starting with this few collection of report. On the downside footer, you will be able to read this particular subject. Okay, so this is normal nerve conduction study, and it is taken from left common peroneal, and it is recorded from EDB, that is extensor digitorum brevis. So here you can read the name of the nerve, and here you can read the name of muscle. Now the report is in your hand. Now what to do? So we have to start with this reading. So that is 3 millisecond, that is sweep speed. So in this graph you can see there are large square as well as small square. So 3 millisecond means horizontally 1 centimeter, it is equal to 3 millisecond. Horizontally 1 centimeter, it is equal to 3 millisecond. Okay, if you don't remember, just remember the SD curve, strength duration curve. So strength was on vertical axis. Okay, so that was having unit of volt, and duration was on horizontal axis. So that was having this unit of millisecond. The same thing is here. Okay, this is also explaining in the same way. So 3 millisecond, it is definitely duration. So it will be taken horizontally. And 5 milliwatt. 5 milliwatt, it is sensitivity or gain. So vertically 1 centimeter, it is equal to 5 milliwatt. Clear? And this potential was taken at 84 milliampere intensity. So now you know sweep speed, that is horizontal unit measurement, 5 milliwatt, that is vertical unit measurement, and 84 milliampere, that is intensity. This was taken at ankle, and second was taken at head of fibula. Recording point is same, both, it is extensor digitorum brevis. Okay, so now we have read this. Now what to read? So we have to identify this latency. Okay, what is latency? So here you can see 4 markers. You have to see it clearly, because in 4 markers, all 4 they are not same. 2 are vertical. This is vertical. This is also vertical, and these 2 are horizontal. Okay, horizontal. This is also horizontal. Clear? So 2.06. How? So here you can have 1 centimeter or 1 large square. This is 1 large square. So this vertical marker, it is occupying less than 1 centimeter from the starting point. Means from this point A to point B, it is 3 millisecond. But here it is before 3 milliseconds. So it is 2.06 millisecond. Clear? Okay, now second finding, that is 9.11. So how it came? So we have to calculate 1 square, 2 square, 3 square, and something more than 3. Okay, so it is more than 3 square or more than 3 centimeter. So it is 9.11, because 1 square or 1 centimeter is equal to 3 millisecond. Okay, now 9.11 minus 2.06. 9.11 minus 2.06. That will be giving us duration. Yeah, so that is already calculated in this report. That is 7.05. Okay, 7.05. Now coming to amplitude. So amplitude vertically, we know that it is 5 milliwatt. You can read from this, it is 5 milliwatt. So if the amplitude is within this 1 centimeter, okay, it is 5 milliwatt. But here it is less than 1 centimeter. We have to see this vertical only, peak to peak, because these 2 are horizontal markers. You can have look on that. So these 2 horizontal markers from peak to peak. Okay, so it is occupying less than 1 centimeter. So it is not up to 5 milliwatt. It is lesser than 5 milliwatt. So it is 4.35 milliwatt. Okay, it is 4.35, lesser than 5 milliwatt. Why? Lesser than 1 centimeter. Okay, fine. Now just by the side you can have area also. Area means whatever area is occupied by this rectangle, that is formed because of joining of all these 4 markers, that will be area, but that will not be having any clinical significance. So we know we don't need to concentrate on that. Now, this was assessment of first CMAP that was measured at ankle. Now the same is for at head of fibula. Everything latency, amplitude. Okay. Now we have to consider two latencies, because just to remember the formula, MNC means distance between two stimulating point divided by proximal latency, means proximal latency minus distal latency. So 7.01 minus 2.06. Clear? So 7.0106, what will be answer? So it is already mentioned, it is 4.95. Okay, so we have the denominator ready for calculation of velocity. Now what is needed? Only distance between two stimulating points. How to get it? It is simply by putting measure tape. So we put the measure tape and we found that is 21 centimeter. Okay, but they are asking in millimeter. Okay, so instead of 21 centimeter, what we are writing? 210. Okay, now we have numerator also ready. So numerator is distance between two stimulating points, that is 210. Okay, and we have also denominator, that is also ready. So that is 4.95. How it came? So it came from subtraction of these two figures. Okay, 7.01 minus 2.06. Now we have to calculate 210 divided by 4.95. So we have calculation ready, that is 42.42 meter per second. In lower limb, if you have velocity more than 40 meter per second, you consider it okay, normal. More than 40 meter per second in lower limb, you can consider okay. In upper limb, more than 45 meter per second, you can consider okay. Clear? So actually the values are different, okay, from now to now, but on an average you can consider for upper limb 45 and for lower limb 40 meter per second. Clear? So this was how to interpret normal nerve conduction study. Now let us explain with a few examples. So here you can see conduction block. So if you want to record from abductor hallucis, okay, you can identify the location of the abductor hallucis. So definitely it will be in foot. Now we are stimulating on the medial side. We cannot see medial side in this picture, but if you approach from the medial side, okay, medial malleoli posterior side. So you can directly stimulate from that side and it will be recorded from abductor hallucis. So that pathway is normal. There is no injury in this pathway from medial malleoli to this abductor hallucis. That is normal pathway. But when you stimulate proximally at popliteal fossa, so now the impulse will have to travel from this block. Clear? So definitely it will take more time. Latency will be prolonged. Okay, and amplitude will be also reduced. Okay, let us have a report. So of this patient, you can see we have left posterior tibial nerve, and it was recorded from abductor hallucis. Clear? So now when you stimulated at ankle, you have good amplitude, that is 15.21. Here in PPT, you consider that green circle, it is normal, and red, it is abnormal. Okay, so even if I forget, you will be able to identify. So green, it is normal value, and red, it is abnormal value. Clear? So now amplitude, it is 15.21 millivolt. Amplitude is 15.21 millivolt. Clear? So that is very good amount of amplitude. For amplitude, you can say that more than 6 to 8 millivolt in upper limb or lower limb. Okay, you can say that it is normal. More than 6 to 8 millivolt. Okay, amplitude will be considered normal. For motor, for sensory, at least 20 microwatt. Okay, so more than that, it is good. So definitely here it is 15.21. So it is very good amount. Now, but when we stimulated popliteal fossa, so amplitude is only 3.33. So definitely we can identify there is vast difference. So at least this should be at popliteal fossa, it should be at least 50% of 15.21. Yeah, at least it should be 15.2, and 50% of 15.2, it is 7.8. So at popliteal fossa, if you are getting 7.8 or even more, that will be normal. But less than 7.8 in our example, it will be considered abnormal. Clear? So amplitude reduction more than 50%, it is suggestive of conduction block. Clear? So this is how you can interpret or you can diagnose this conduction block. I hope that you all are clear with this. Now Bell's palsy. So here you can see right facial, so that is normal side. So we have to take on normal side. So here we can say it is 2.72 milliwatt. Then this should be considered as 100%. Then this 100% should be compared with normal side, abnormal side. So on left facial side, okay, of the same patient, we are getting 0.66 only. It is normal, right facial as reference value, it is 2.72, and left facial, so it is 0.66 only. So definitely it is lesser than 50%. We should be having no difference more than 50%. In conduction block, we are comparing the amplitude between distal and proximal. In Bell's palsy or facial palsy, we are comparing amplitude between right and left side. Okay, so be clear regarding this. In both, we have to consider at least 50% for normal. So now here, definitely it is quite lesser, because in normal side it was 2.72. So definitely it's lesser than 50%, even lesser than 30% here. So by this, you can also say prognosis. So if your amplitude on affected side, if it is lesser than 10% as compared to normal side, the recovery will happen within 6 to 12 months. If it falls between 10 to 30%, for example, in this patient, so recovery may take from 2 to 8 months. And if it is more than 30%, definitely you can expect recovery within 2 months. Yeah, and this is approved by research also. So here we have to compare amplitude between right and left. Now carpal tunnel syndrome. Most of our patients, they are coming for NCV for this problem only, that is carpal tunnel syndrome. And nowadays the surgeons, they are also not operating before they have report. Why? Because the patient has Mediclaim, and Mediclaim company, they are asking for documentation. If the surgeon is operating decompressing this median nerve entrapment, so they have to produce the proof to Medicare company. Mediclaim company, they need proof that this patient was requiring this surgery. Okay, if they don't have NCV report, they will not disperse the amount of Mediclaim. So here carpal tunnel syndrome, you can see. So we have this median nerve. We have to stimulate proximal to wrist, and we have to record distal to the wrist. That is at APB, that is abductor pollicis brevis. Now you have to stimulate at elbow again, and you have to record at APB, that is abductor pollicis brevis. So whenever the impulse is passing from this wrist to APB, latency will be prolonged. Clear? But again, velocity will be normal. Why? Because the velocity will be between wrist and elbow in case of motor nerve. Is this clear? So latency in case of motor nerve, it will be prolonged. Why? Because it has to pass from compression. But velocity will be calculated between wrist and elbow, where the nerve conduction is normal. So amplitude and velocity will be normal, but latency will be prolonged for motor nerve. Okay. But for sensory, stimulation is given at the wrist joint. Okay, at 3 centimeter proximal to the wrist joint, and it will be recorded from digit. Okay, that is from index finger. So here for sensory, it has to travel from this compression, and it is not having second point. So in sensory, velocity and amplitude will be also affected. So in short, in motor conduction of the median nerve, latency should be prolonged, but amplitude and velocity should be normal. In sensory, all three may be affected: latency, amplitude, and velocity. Now let us see the report. So here you have a patient of the right median nerve symptoms. It is recorded from abductor pollicis brevis. Then latency, that is 6. That is, you can calculate here 1, 2 square. So 1 minute. Now you can see this 1 centimeter and 2 centimeter. So that will be 6 millisecond here. Okay, because the sweep speed is 3 millisecond. So 6 millisecond is prolonged latency. Ideally, it should be less than 4.4 millisecond. More than 4.4 millisecond, it is suggestive of carpal tunnel syndrome. So definitely more than 4.4, here it is 6. Okay, marked with red color. but at the same time, amplitude and velocity should be normal. Why? Because this amplitude and velocity, even if they are abnormal, it is suggestive of neuropathy instead of carpal tunnel syndrome. Clear? So this should be more than 4.4 millisecond. Now, we have to check ulnar nerve also. Clear? Because if the ulnar nerve is also affected, then it is not carpal tunnel syndrome. It is neuropathy that is commonly affecting median as well as ulnar nerve. So we took this ulnar nerve finding also. So that is 2.77. Now, how to identify the difference? So this difference between median and ulnar, that should not be more than 1.1 millisecond. Clear? So latencies of motor conduction of median as well as ulnar, difference should not be more than 1.1 millisecond. So in this example, 6 minus 2.77, so that is 3.23 milliseconds. So definitely it is more than 1.1 millisecond. So it is suggestive of carpal tunnel syndrome. Clear? Because if the median node latency is prolonged, and at the same time, if the ulnar node latency is also prolonged because of polyneuropathy, then this difference will be remaining same. Why? Because latency of median as well as ulnar both are prolonged. But in CTS, what happens? Only latency of median nerve is prolonged. At the same time, latency of ulnar nerve is not prolonged. Okay, so this difference will increase. Okay, latency difference of these two nerves will increase. Okay, similar way, we have to check difference of sensory also, because many times it is possible that this motor difference will not be coming, but sensory will be coming if the patient has less symptoms or less involvement. So in motor, difference may be less than 1.1 millisecond, so that may be considered as normal initially. But when you check for this sensory component, so this difference will increase. So here it is 4.33, you remember for a while, 4.33 millisecond. Okay, here the amplitude is also reduced, okay, and velocity is also reduced. Why? Because here the amplitude and velocities, they are also affected just because the impulse has to travel from this compression. Here in motor nerve conduction velocity, this was common component and we were taking 2 points of stimulation. So this compression point was deducted or subtracted, but here it is not deducted. Yeah, so amplitude and velocity will be also affected along with latency in case of SNCV. Now, just we have remembered 4.33. Now we are taking ulnar nerve also, and it is 1.95. Okay, so 4.33, 1.95. So we have to identify the difference. 4.93 in this patient minus 1.9, so it is near about 2.98 millisecond. Ideally, it should be less than 0.2 millisecond. More than 0.2, it is suggestive of carpal tunnel syndrome. Clear? So in short, there are actually 8 criteria, but basically from these 3 criteria, you can say that if the distal latency of median motor is more than 4.4 millisecond, it is CTS. If the difference of latency for motor nerve conduction study, if it is more than 1.1 millisecond, it is CTS. And if the difference of latency between ulnar and median, obviously, and if it is more than 0.2 in sensory, then also it is CTS, carpal tunnel syndrome. But ideally in report, it should not be written carpal tunnel syndrome. Even if you are performing, no need to write carpal tunnel syndrome. It should be written entrapment of median nerve at rest. Clear? Because we don't know whether it is compressed in carpal tunnel or anywhere else. Clear? That should be by the structural analysis, by X-ray or MRI, it will be identified. Definitely it will be in carpal tunnel only. But from this electrophysiological finding, we are not supposed to write in report that these findings are suggestive of carpal tunnel syndrome. Okay, what we have to write? Entrapment of median nerve at wrist joint. Clinically, it will be carpal tunnel syndrome. Clear? Now, you can see a report of common report generation. These are median nerve potential. So you can see they are quite right. As compared to this third and fourth potentials, they are taken from ulnar nerve. Yeah? So you can compare, this is quite prolonged. This is because of latency prolongation. And this is quite near or quite left side, okay, because these two are ulnar nerve. Third and fourth, they are ulnar nerve. First and second, they are of median nerve. If this all four they are affected, all four they are shifting to right side, that is polyneuropathy. Yeah. Okay. Now coming to foot drop. So here you can see one side is affected, and one side the patient is able to perform this dorsiflexion. How to check electrophysiologically? So we have a report. So this is taken for posterior tibial nerve. Okay. Again, there will be question if there is foot drop, why we should go for posterior tibial nerve? But we have to prove that posterior tibial nerve is normal. So here all the findings they are normal. You see this amplitude, as I told, more than 6 to 8 millivolt in motor you consider normal. Yeah, so definitely they are more 15 and 14. Okay, velocity more than 40 you can consider as normal in lower limb. So here it is 51.33, so that is very good value. Tibial nerve is normal. Now go for peroneal. So that is common peroneal nerve. Okay, common peroneal nerve recorded from EDB, extensor digitorum brevis. You are not able to record the potential. Okay, no potential. So what does it mean? It means that the patient is having complete axonal degeneration. Complete axonal degeneration. Clear? Now, whenever you have this type of the potential, so you can cross-check with SSEP. You check for surge Faradic current response. So if the response is not there with surge Faradic current, definitely you are right that you have not received any potential. Clear? So no need to cross-check also. Just you cross-check with SSEP. Okay. Many times if you are clinicians, okay, and you are referring for NCV, so before referring, you just check SSEP. If the SSEP is not responding, no need to send the patient for NCV, okay, and unnecessarily waste the money and energy of that patient. Because if the SSEP is negative, definitely the patient will not be able to get this potential, even if he goes for NCV, okay. So check for SSEP and then you refer the patient. Okay, now again there will be question that why we check tibial nerve, what was the meaning of that. So if it is foot drop, we have to check tibial nerve, because if the tibial nerve is also affected, we need to check sciatic nerve. But here the tibial nerve is normal, so we don't need to check sciatic nerve. Okay, just by checking this, okay, it is sufficient. Clear? But if you are finding abnormality in tibial also, then definitely there may be some problem at sciatic. Now, coming to polyneuropathy. So that is very common, diabetic polyneuropathy, alcoholic, GBS. Now, as I told you, Mediclaim company, they are also asking this NCV report for GBS, polyneuropathy. Why? Because the treatment of GBS is costly. IVIG, that is intravenous immunoglobulin, that is quite costly treatment. Okay. Generally, for any 2 kg, they need 5 milligram of IVIG. Okay, and that one unit of 5 milligram, that is costing from 8,000 to 14,000. Clear? So if the weight is up to 50 kg, the patient may be having expense up to 2 lakh. And if the weight is more, definitely the expense will increase. Okay, this we have considered 8,000 rupees for 5 milligram of IVIG for 2 kg of weight. Okay, sometimes even the price may increase based on company, sometimes even weight will be more. So here also Mediclaim company will ask for evidence, documentation that the patient was having GBS. So here also the role of this, it is very important. NCV, for example, this is posterior tibial nerve right side recorded from abductor hallucis. So amplitude is normal. Here you can see amplitude is normal, but velocity is affected. Amplitude normal means there is no axonal degeneration, but velocity is affected means demyelination is there. Okay, the name itself it is telling acute inflammatory demyelinating polyneuropathy. So the demyelination is there. Okay. Now we have also checked sensory median nerve. Okay, so amplitude we discussed that it should be at least 20 microvolt. For motor 6 to 8 milliwatt, for sensory at least 20 microwatt in general. Okay, again I repeat, there are separate values for all the nerves, but still generally we are not always with the chart of this NCV values with us. So you can remember these values, okay, roughly. Here you have definitely it is less than 20 microwatt amplitude, as well as conduction velocity is also less. Okay, generally you should be able to get at least 45 meter per second as it is upper limb. So it is also less. So the patient is having reduction in amplitude as well as velocity. So it is axonal degenerative as well as demyelinating, sensory also and motor also. So what we are writing? Axonal degenerative and demyelinating sensory motor polyneuropathy. Okay, polyneuropathy, where we are writing, definitely we must be having reports of other nerves also. Here this is just for lecture purpose, so I have kept only 2 nerves, but at least 4 nerves should be affected when you want to say it is polyneuropathy. Now, radiculopathy. So that is based on F-wave and H-reflex. So here the axon will be affected at intervertebral foramen. Clear? So let us go for the report. Here you have F-wave. This is F-wave. Now these are M waves. Okay, at 5 millivolt you can see. These are F waves. At 1 millivolt you can see. Millivolt means vertical. Okay, you remember strand duration curve. Millivolt means vertical. Horizontally it is 10 millisecond per division. Okay, millisecond means what? Horizontal. Clear? Now this is for posterior tibial nerve. So it is for lower limb. So for lower limb, as we discussed, the latency should be less than 60 millisecond. So here you can see F mean. F mean means this is F minimum and F maximum, and the difference of these two will be taken as chronodispersion, and average of these two will be considered as F mean. Clear? So here F mean is 54.69. So definitely it is less than 60 millisecond. So it is normal. Okay, but if it is more than 60 millisecond here, because it is lower limb, it will be considered as radiculopathy. Clear? Now, this is H-reflex. Okay, these all are this H-reflexes, and this all are M wave, and these all are H-reflexes. Clear? M you can see with 5 millivolt, and H-reflex you can see with 500 microvolt. Clear? Now again this is same horizontally sweep speed, it is 10 millisecond per division. So definitely for lower limb, right posterior tibial, for H-reflex it should be up to 32.5 millisecond. Here it is more than that, that is 35.68. Yeah, 35.68. So definitely it is prolonged. So it is abnormal. It is suggestive of dorsal root pathology or dorsal root involvement. Yeah. So for H-reflex for lower limb, it should be maximum 60 millisecond, and for F-wave it is maximum 60 millisecond, and for H it is maximum 32.5 millisecond. Now, myogenic lesion. So for that we have to go with EMG, that is electromyography. So here you can see this is voluntary activity. So sweep speed it is 10 millisecond per division. Millisecond means horizontal. Sensitivity or gain, that is 100 microvolt per division. So 1 square or 1 centimeter is equal to 100 microvolt. So here you can calculate 1, 2, 3, 4, 5, 6, and more than 6 but less than 7. So here it will be falling like 650 microvolt. So that will be considered normal. Okay, amplitude of normal MUAP will be ranging from 100 microvolt to 2 millivolt. So definitely it is more than 100 microvolt. It falls around 650 microvolt. Clear? So it will be considered normal. This is for tricep. Okay, but when we go for facial muscles, this is for frontalis. So definitely the facial muscles, they are not having that much of this strength, but still they are having more than 1 centimeter of span. So it is more than 100 microvolt. So this is also normal. Now, if it is affected lesser than that, it is suggestive of abnormality. Means the patient is suffering from muscle weakness or myogenic lesion. Now, this is interference pattern. So that is checked with resisted movement. So ideally, this blank part, okay, whatever you can see, it should be also covered with this particular color. Okay, this is black and white report, but in screen it may be red, it may be yellow, okay, based on the different softwares. So we can say that if it is of red color, you can ask your patient to cover whole screen with red color. Okay, so that will be one of the motivation. So here you can see patient is performing this interference pattern. Patient is performing resisted movement. Okay, so it is moderate. Okay, it is neither poor or it is neither good. Okay, so it is moderate, you can see. But if the patient is able to cover this blank part also, definitely it is told that patient is having very good amount of this strength. Okay, patient is having good recruitment of fast twitch fibers. Now, the summary part. So initially, traditionally, we were doing SD curve. So that was telling us the status of muscle, whether it is normal, that is fully innervated, or PRD or CRD, that is partial reaction of degeneration or complete reaction of degeneration. We were also doing FG test, so that was showing status of the motor nerve, that whether the degeneration is present in this motor nerve or absent, but we were not able to quantify it, and we were unable to do anything for sensory nerve. So SD curve was for status of muscle and FG test was for status of motor nerve. Now, with this EMG NCV, we are able to identify all the structure of neuromuscular system. Likewise, EMG. So if you suspect any problem in muscle, you can think of EMG. If you suspect any problem in neuromuscular junction, you can think of RNS, that is repetitive nerve stimulation. If you think of any problem in motor nerve, go for MNCV. If you suspect any problem in sensory nerve, you can think of SNCV. If you think of any problem in proximal root of sensory pathway, you think of H-REFLEX. And if you think any problem in this proximal axon of motor pathway, you think for F12. And for any abnormality in spinal cord as well as cerebral cortex, you think of yoke potential. But frankly speaking, nobody is doing yoke potential nowadays. But definitely all these tests, they are done EMG, RNS, SNCV, MNCV, H-REFLEX and F-wave. Okay, all this are practically performed and patients that are coming with report. Okay, any question? If you have any question,
No,
you
sir.
can ask.
No, sir.
No, sir.
No, sir.
Okay, so it was very nice experience to again communicate with all my ex-students and nowadays definitely professionals. So it was very nice effort from Rahul. I again thank Rahul for arranging this session. Okay, thank you. And by learning
To have you.
this, it's not like that.
Hello, sir.
I have yes.
Sir, good evening to the screen. Sir, can you please give some highlight regarding the acute and the chronic interference pattern with the
Acute and chronic interference pattern.
acute and chronic interference pattern of the nerve lesions? Whether we can differentiate between nerve lesion or it is like myogenic lesions.
Okay, we want to differentiate between the nerve lesion and muscle lesion from EMG. Am I right?
Yes, sir. Acute
Okay.
conditions and chronic conditions. Can you please give highlight on it?
See, acute and chronic, many times what is happening, whether you are thinking for NCV or EMG, so in acute condition, the findings in EMG and NCV will be less promising because the clinical condition has acute condition, inflammatory process is going on, but there is no any structural damage or functional damage that has occurred yet. Clear? So many times it happens that whenever your patient is having acute condition, your findings will be up to normal or towards normal side, whether you think of EMG or NCV. Clear? But whenever a patient is having chronic condition, so at that time the findings are coming to abnormal side. So many times it is possible that if your patient is having CTS, the patient is complaining of severe pain, but it is possible that the report may be towards normal side. Why? Because the structural problem has not started. But the thing is, in chronic condition, patient has adapted the pain. So patient is complaining less about the pain, but findings in report will be more. Similar will be for EMG. Okay, if you think of acute pain, okay, if you think of acute pain, so it is possible that because of acute pain, patient will not be able to contract muscle fully. So that will be definitely reflected on EMG interference pattern. Okay, but still weakness is different. Okay, if you are finding weakness in chronic condition, if you are finding IP pattern reduced in chronic condition, so definitely it is weakness. But if you're finding that in acute condition, so it may not be because of weakness, because weakness will take some time to develop. It may be because of pain, patient is not performing well. You can simply correlate with MMT. If your patient is having pain because of acute conditions, even though strength is there, you will not be getting full MMT. But just think that patient has come with analgesic. Clear? So in that case, we'll be able to get full strength. Same will be reflected in interference pattern. So you have to identify what is the amount of pain. Okay, even though in the presence of pain, patient has come with medicine or not, because that will also matter here. Same will be mattering in case of neuromuscular junction abnormality, because if the patient has come with the medicine, report will be coming normal. Okay, so in case of acute and chronic, you have to identify clinically also. In acute condition, you have to think because of inflammation, because of pain, patient is not performing, or actually there is weakness. Are you getting my point?
Yeah, definitely, sir. Always correlate with the clinical outcomes as well.
You have to depend on clinical finding also, because structural change will be less in acute condition. Okay, like if you think of weakness, so weakness has not established in acute condition. So ideally you should be having good IP pattern. Okay, but it may be reduced because of this pain or inflammation. That is different. Okay, but in case of chronic, if it is reduced, definitely it is weakness. Okay, and what was your second question? Second question?
Sir, the same key acute and chronic के अंदर, if in case there is nerve, suppose a nerve injury patient comes with the acute, and when we do with the follow up of the same patient, so does we get any identification for it after considering a report only?
So for now also it will be remaining same. In acute condition, clinically patient will be having more symptoms. So if you take any clinical scale for the assessment, it will show more problem. Electrophysiologically, it will show less problem. But in chronic condition, the patient has adapted, so clinically it will be giving less problem if you check by any assessment or scale, but electrophysiologically it will show more problem because there are permanent structural changes.
Okay. Thank you so much, sir.
Okay, welcome. Any other question?
Yes, sir. Sir, I wanted to ask, ideally, should we wait for 21 days before ordering report?
Pardon, I'm not able to listen properly.
Sir, ideally, should we wait for 21 days before ordering a NCV report if we are suspecting a nerve injury?
Actually, it's not like that to wait for 21 days, but the nerve degeneration will take time up to 21 days. So for example, if the nerve injury has occurred today, definitely you can go for NCV today also, but you repeat it on 21st day again. Okay, so I can say that whatever the injury is today, that I can measure with today's report. Okay, but it is progressive procedure. Okay, the damage is still continuous, so definitely the picture will be different on 21st day. Clear? So after 21st day, it is compulsory, you can say. Before that also you can think of doing this. Clear?
So, sir, I have a patient actually who was operated yesterday for radius and ulnar fracture. But we are suspecting radial nerve injury because he's not able to extend wrist. Plus, he also has sensory loss in the first thumb space, web space of the thumb. Okay. So, we are deciding on whether to send the patient for NCV right now or should we wait after 10 or 15 days to confirm a nerve injury?
You can send now. Complete your sentence.
Yeah, and how will that impact on our treatment right now? So patient is immobilized in a cast, but can we start ES if we are suspecting a nerve injury right now?
What you can do, first you check SF. Okay, if you are not getting response with SF, no need to send patient for NCV now to save patient's energy and money. Clear?
Okay, sir.
Okay, and if you are getting SF, definitely the patient will be able to extend in near future also. But if you want to give more satisfaction and if you need documentation, you can send your patient now also for NCV. But even if you send now, you send again after 3 weeks. Because that report will be conclusive. This report will be giving picture of today. Okay, but that will not be conclusive to decide any policy. Okay, you cannot take any decision from today's report. For taking any decision, you should take the report after 3 weeks.
Okay, thank you so much, sir.
Okay, welcome. Any question? Okay, I think there are no questions. And even later, if you have any question, you can call me and we can discuss. Okay. So this slide is telling that by attending this lecture, we are not master in electrodiagnosis. This is just beginning of it. But now, if you continue, if you just brush up, definitely you will be able to interpret the reports and you will be able to take some clinical decisions based on patient's report. Okay, and this lecture is prepared from this references. Thank you.
Thank you, sir.
Hello, sir.
Okay.
Hello.
So, hand over to Rahul. Yes?
Yeah. Everyone is eager to interact with you right now.
Yes.
So we'll allow 5 minutes if you have time, sir.
Hello?
Hello.
Yes.
Hello. Sir, everyone is eager to interact with you for 5 minutes. So if you are
Sure.
available, yeah.
I'm
Yes,
available
you can
only.
unmute yourself turn by turn, please.
Hello.
Yes, yes.
Am I audible?
Yeah, it's Prashant, sir, I guess.
Yes, I'm Prashant. Yes, yes.
Yeah.
Hello, sir. Good evening.
Good evening.
Sir, I would just like to request you to enlighten our students to, about the licensing or about the authority of giving an NCV report to the patients. Whether the physio can do such report and give it to the patients as a diagnostic tool or not.
Definitely we can give. Definitely we can give. If someone is opposing, you can write to council and council will send the notice. That's it.
Okay.
As per definition of physiotherapist, we can do the reports. Okay, you go to the definition of physiotherapy. Okay, in GSCPT, so it is allowing to do. Okay, many neurophysicians they are claiming that only they can do, but the thing is practically you can argue. Okay, for example, I was in Civil Hospital Ahmedabad where there were 6 seats of DM Neuro, but in no setup of this neurology department, there was no EMG NCV machine. Even in government hospital, maybe Ahmedabad, maybe Vadodara, okay, even Jamnagar, Rajkot, in government hospitals, physiotherapists, they are doing NCV. So definitely it is one of the trend, or if something can be done in government setup, so definitely we can do in private setup also. But the thing is, as a physiotherapist, we should not accept duty I will come to your clinic to perform EMG NCV of your patient. Okay, definitely if you go, you sign. Because many of us, they are doing reporting, they are doing everything well, and then the sign will be done by neurologists. So that is not actually good. That degrades the profession.
Thank you so much, sir. That was the only thing I wanted from your mouth to be conveyed to the students, because in future many of these will probably try to accept this as a profession, and probably that will somehow help them. Your inputs will help them. Thank you.
Sure. Welcome.
Okay, anyone else would ask to enlighten anything on any particular topic or anything?
We would like to thank Sir and even Dr. Rahul for arranging this. I was always worried, I missed this portion of understanding and gaining lecture from Ashish Sir regarding electro-diagnosis. But I'm so happy that finally I could attend this, and thank you so much for that.
Well,
Special thanks to Ashish sir, he made time for us.
Yes, sir. Very much. Thank you.
Yes, of course.
No, it's my pleasure to take lecture of all the students. It's my pleasure actually.
Thank you so much, sir.
Well.
Okay, so I guess we'll conclude here as there are no doubts. Anyone has no doubts? Okay, fine. So we'll conclude here, sir. Thank you so much again.
Sure.
Yeah.
Okay, fine.
Okay. So we are leaving.
Okay, bye to all.
Thank you all for joining.